Hi everybody, today I'll be discussing atherosclerosis and the significance of flow-mediated dilation in the assessment of vascular health. Atherosclerosis is a chronic and systemic disease where plaque builds up in the arteries, causing hardening and narrowing, as seen in the image. Consequently, this can lead to cardiovascular diseases including stroke, heart attack, and peripheral vascular diseases. The exposure of cardiovascular risk factors leads to development of cell changes, in this case, arterial endothelial dysfunction. This is where there is an imbalance between vasodilating and vasoconstricting substances produced by the endothelium. This can both be the result of and contribute to cardiovascular diseases. To assess endothelial function, non-invasive tests are used. In particular, flow-mediated dilation is the most widely used. This measurement is done by inducing reactive hyperemia and measuring the resultant relative increase in blood vessel diameter by ultrasound. This is an essential tool to assist understanding of the etiology of cardiovascular diseases and determines the efficacy of therapeutic treatments that target vascular health. Recent studies, which will be referred to in this presentation, explains the importance of this form of measurement due to advancements in the field of work. Today's objectives are to provide background information on atherosclerosis, in particular endothelial dysfunction, and the importance of the non-invasive testing. Hopefully you gain from this presentation greater knowledge of endothelial dysfunction, what it is, how it's caused, how flow-mediated dilation is used to assess, and interventions for atherosclerosis. I will begin with the major concepts, analysis of these, followed by an explanation and discussion on the risk factors and the possible interventions. I'll then conclude with some practical applications which could be useful in exercise physiology. Atherosclerosis is occasionally triggered by subtle physical or chemical insults to the endothelial cell layer of the artery. It is an insidious process where the clinical manifestations do not typically show evidence for 20 to 40 years, and in some cases even longer. The widespread accepted theory in current literature is the response to injury theory, describing that the earliest event in atherosclerosis is injury to the endothelium by physical injury or stress as a result of hypertension, turbulent blood flow, or hyperlipidemia, just to name a few. This injury to the cell provokes the endothelium cell to produce an inflammatory response. The cells undergo a change in shape, and the tight junctions between them loosen, increasing permeability to fluids, lipids, and leukocytes. As seen in the diagram, the first sign of atherosclerosis is fatty streaks, consisting of lipid-containing foam cells. These fatty streaks then evolve into atherosclerotic plaques. Over a period of time, the accumulation of lipid and smooth muscle cells leads to the beginning of the lesion. Following this, rapid-growing plaques expand due to the quick lipid deposition, which their thin fibrin caps are prone to rupture. Studies also discuss nitric oxide being crucial in determining whether atherosclerosis will develop or not. Nitric oxide bioavailability also characterizes endothelial dysfunction, which is now recognized as a reversible precursor of atherosclerosis. Consequently, these cause an inability of the endothelium to initiate vasodilation. The role of endothelial dysfunction as a pathological link is significant to practitioners as it is associated with cardiovascular risk factors and heart disease. The pathogenesis of endothelial dysfunction is multifactorial. However, oxidative stress is the most common cellular mechanism. The risk factors associated with atherosclerosis, in particular endothelial dysfunction, are similar to those of cardiovascular disease. Cigarette smoking, as well as passive smoking, is connected with impairment of endothelium-dependent dilation and acute coronary thrombosis, suggesting arterial damage. It is also a cause of increased platelet thrombus formation, ultimately leading to arterial occlusion. Many studies also show that endothelial dysfunction is closely related to atherosclerosis in those suffering from diabetes, both type 1 and type 2. It is an early marker of vascular disease in type 2 diabetes. However, it does not seem to fully manifest until later in the course of type 1 diabetes. Although the diabetic state predisposes to endothelial cell dysfunction in atherosclerosis, it does not cause it. Studies show that diabetes is primarily attributable to oxidative stress, accelerating atherosclerosis and development of endothelial dysfunction. As always, the effect of other factors make this risk factor complicated. However, there is growing evidence suggesting the coexistence of insulin resistance and endothelial dysfunction. This cell dysfunction can also be found in patients with hypertension. Studies indicate that endothelium vasodilation was impaired in these patients. Once again, there is contrasting studies which suggest that this is not universal in patients with hypertension. High cholesterol levels show a strong relationship with impaired endothelial function. Cholesterol levels are important in the production and release of endothelium-dependent nitric oxide, with lower levels improving endothelial function. Cellular senescence in vivo, which is an irreversible growth arrest, contributes to the pathogenesis of atherosclerosis. Evidence suggests that aging, in general, is associated with reduced arterial elasticity, which is parallel with changes in impaired endothelial vasodilation. A high-fat diet impairs endothelial function both directly and indirectly through increases in LDL cholesterol concentrations. Combined with a lack of exercise, also consistently shows endothelial dysfunction. Obesity also relates to the effect of the metabolic syndrome on the biology of endothelium-derived nitric oxide. Other risk factors include family history, acute renal failure, end-stage renal disease, and being male or women after going through menopause. Although these risk factors have been identified through studies, there are still many unanswered questions regarding the mechanisms by which they contribute to the development of atherosclerosis. Due to advancement in science and technology, endothelial dysfunction can now be detected using simplistic, non-invasive, and inexpensive methods. Flow-mediated dilation is a non-invasive method using ultrasonography on the brachial artery and is frequently used. A sphygmomanometer on the forearm creates flow stimulation into the brachial artery. This is inflated until creating ischemia by stopping the antegrade blood flow. As a response, vasodilation occurs at the resistance arteries, distal to where the flow is blocked. Once deflated, a reactive hyperemia occurs. What is measured as flow-mediated dilation is the percent difference between the diameter measured after reactive hyperemia and the basal diameter. It is important that prior to using flow-mediated dilation for evaluation purposes, that measurement technique and values are standardized. Recently, a new automated analysis system was introduced, which reduces variability and analysis time of flow-mediated dilation measurement. The simplicity of this method is beneficial for using on large populations of patients, leading to large studies for investigation. Although limitations with using flow-mediated dilation do exist. This technique is highly dependent on the skills of the examiner and high-quality ultrasound images. For accurate analysis, several months of training by experienced individuals combined with continuous performance is mandatory. This will increase the optimal quality and consistency of the data. The image interpretation is also subject to bias, unless edge detection techniques are used for measurement of vessel diameter at critical time points. Overall, this is an essential tool that will assist in our understanding of the etiology of vascular diseases and determine the efficacy of treatments targeting vascular health. Other routine clinical assessments used to evaluate health status in persons with atherosclerosis include forearm perfusion technique, pulse wave analysis, markers of inflammation, and laser Doppler flowmetry of the skin. Most pharmacological interventions intend to increase nitric oxide synthase activity and release, inhibit nitric oxide degradation, and enhance activity of endothelial cells. In particular, studies have shown that antioxidants improve endothelial function and reduce oxidative stress in participants. Statins are suggested to achieve vascular protection through mechanisms beyond their primary actions. partly due to their lowering LDL cholesterol effect. Amino acid supplementations prevent or slow down the progression of atherosclerosis. ACE inhibitors and AT1 blockers target the risk factors linked to endothelial dysfunction, in particular hypertension. Beta blockers exert endothelial protective effects and improves endothelial function and vasodilator responses. The most effective non-pharmacological measurement is aerobic exercise, which reduces production of oxidative stress. Fish oil supplementation can lead to an improvement of endothelin-dependent vasodilation by restoration of nitric oxide availability. Dietary modifications, including reduced salt intake and tea consumption, improves arterial and peripheral vascular compliance. Dietary management is also aimed at lowering cholesterol levels. Vitamin C protects the endothelium by preventing nitric oxide scavenging, while vitamin E acts as a lipid-soluble antioxidant. Other interventions include a change of negative lifestyle habits. The cessation of smoking in many studies has showed significant benefits. It is all well in knowing all this information, but unless it can be practically applied, then it's really useless. It's important to know that this information so you can apply it to your clinic and to your patients. This can be done by explaining the importance of aerobic exercise in endothelial function. This lifestyle modification may encourage your patients to begin and then adhere to your exercise program. Another way this information can be utilized is encouraging patients to change effectively detrimental lifestyle habits. Explaining the risk factors that lead to atherosclerosis may positively influence your patients to quit smoking or eat healthier. The information regarding flow-mediated dilation should be important to exercise physiologists so they know the extent to which is required to correctly analyze these ultrasounds. It is worth the effort for a professional to perform these tests so you as a practitioner can obtain the most accurate readings to use for prescribing most appropriate exercise regimen for your client. Finally, this shows the transition from a stable to an unstable disease state. As a result, study of endothelial function has emerged as an important point that complements measurements of circulating risk factors, imaging techniques for structural arterial disease burden, and traditional cardiovascular clinical outcomes. In conclusion, the main points to take home with you today are that endothelial dysfunction can be both a cause and outcome of atherosclerosis, the response to injury theory's explanation that injury to endothelium is caused by physical stress, nitric oxide bioavailability also characterizes endothelial dysfunction, which is now recognized as a reversible precursor of atherosclerosis. The risk factors can be closely related to those of cardiovascular disease, smoking, diabetes, hypertension, and hypercholesterolemia of the most concerning. One of the clinical assessment methods used to be detected is flow-mediated dilation, which is non-invasive using ultrasound. Pharmacological interventions including ACE inhibitors, beta blockers, and antioxidant agents. Non-pharmacological interventions include aerobic exercise, dietary management, fish oil, and vitamin supplementation, and that this can be applied to exercise physiology so the correct exercise regimen can be given and the importance of exercise for health can be described. It is important to note that endothelial dysfunction still requires much more research, and as technology becomes more advanced, more questions regarding this topic are being accurately answered. However, the studies used today are reliable resources due to their high validity by using large participant numbers and control groups. So hopefully you have gained something from today's presentation, which can be further utilized in your field of work, in particular for exercise physiologists, which it can apply to their clinic and when prescribing exercise programs to their patients.